The first part of the video presentation on the role of endoscopic ultrasound EUS in solid pancreatic lesions deals with the problem of detection. Due to its unrivaled spatial resolution, EUS is the most accurate technique for the detection and exclusion of solid pancreatic lesions. EUS is recommended in the case of inconclusive findings of other imaging techniques and for localization of insulinoma. Screening for early pancreatic cancer in asymptomatic high-risk individuals is currently under discussion. A 26-year-old female patient presents with recurrent unexplained hypoglycemia indicative of insulinoma. Transabdominal ultrasound, CT, and MRI are inconclusive. EUS reveals a hypoechoic focal pancreatic lesion of 12 by 7 mm near the portal confluens. Color-coded duplex sonography shows vascular signals within the tumor, and after injection of the ultrasound contrast enhancer SonoView, arterial hyperenhancement is demonstrated. Real-time elastography depicts intermediate stiffness, comparable with the surrounding pancreatic parenchyma. The hypervascularity of the tumor, which is typical for pancreatic neuroendocrine tumors, is again shown using contrast-enhanced endoscopic ultrasound with low mechanical index. Surgical resection is performed, and final diagnosis is solitary pancreatic insulinoma. The second case of a 45-year-old woman who is examined because of idiopathic acute pancreatitis impressively demonstrates the capability of EUS to also detect very small subcentrometric lesions. Radial EUS excludes a biliary cause of pancreatitis and demonstrates normal pancreatic parenchyma. However, a 5 mm small hypoechoic solid lesion of the pancreatic neck is detected. Longitudinal EUS is performed in order to characterize the lesion. The pancreatic duct is slender and may be followed from the hypoechoic ventral portion of the pancreas to the more echogenic dorsal pancreas. The small hypoechoic tumor is demonstrated near the portal confluens. Color-coded duplex sonography shows some vessels in the periphery of the lesion. In real-time elastography, the tumor tissue has a slightly higher stiffness compared to the surrounding pancreatic parenchyma. The tumor now is sampled using a 25-gauge aspiration needle. 3 needle passes are performed. Cytological smears are prepared. Aspirates are highly cellular. Small monomorphic cells with scant cytoplasm resembling lymphocytes are arranged in loosely cohesive groups and pseudo-rosettes. Immunocytochemistry is positive for synaptophysin, and the diagnosis of a non-functional neuroendocrine pancreatic tumor is made. The third case proves the ability to diagnose pancreatic cancer in very early asymptomatic stages. An 82-year-old female presents with an incidental finding of constantly high values of serum lipase and marginal dilatation of the pancreatic duct in transabdominal ultrasound. Longitudinal EUS shows a hypoechoic solid mass of the pancreatic head measuring 13 by 11 mm, which is obstructing the main pancreatic duct and some side branches. Real-time elastography is used to assess the relative stiffness of tumor tissue compared with the surrounding pancreatic parenchyma, which appears predominantly green. The tumor tissue is displayed in dark blue color, indicating a very high stiffness compared to pancreatic parenchyma. Contrast-enhanced endosonography with low mechanical index reveals hypovascularity of the tumor compared with the surrounding pancreatic parenchyma. These findings are indicative of ductal pancreatic adenocarcinoma. However, the patient rejects surgical treatment, and therefore EUS-guided biopsy is performed using a 22-gauge aspiration needle. A small tissue core is sampled and fixed with formaldehyde. Histological examination gives proof of adenocarcinoma. This case of a 50-year-old female patient with recurrent pancreatitis attacks shows that detection of pancreatic tumors is much more difficult in patients with chronic pancreatitis. Transabdominal ultrasound is compatible with chronic pancreatitis, and a pancreatic head pseudocyst is demonstrated. Longitudinal EUS shows typical criteria of chronic pancreatitis, in particular dilatation and irregular contour of the main pancreatic duct, dilated side branches, and non-shadowing hyperechoic parenchymal reflexes. Peripancreatic lymph nodes and a discrete effusion are features of acute pancreatitis attack. In the region of the pancreatic head, a pseudocyst with some debris inside is found. A striking finding is hypoechoic tissue at the level of the papilla, resulting in obstruction of the bile duct, and of the pancreatic duct as well. As expected, real-time elastography shows high tissue stiffness not only of the tumor, but also of the pancreatic parenchyma. Sonoview is injected, and contrast-enhanced endoscopic ultrasound with low mechanical index is performed. The suspicious solid tumor of the ampullary region is apparently hypovascular compared with the pancreatic parenchyma. Diagnosis is made of an ampullary cancer with obstructive chronic pancreatitis, and surgical treatment is decided. The shown clinical cases illustrate the findings of several studies showing a high diagnostic yield of EUS in patients with inconclusive findings of radiological imaging, like suspicion of a tumor, focal or diffuse enlargement of the pancreas, focal structural changes, or dilatation of the pancreatic or the common bile duct. Pooled data of these studies show that in approximately 10% of cases, a pancreatic neoplasm is found by careful examination. Moreover, advanced endosonographic techniques like real-time elastography, contrast-enhanced endosonography, and EUS-guided biopsy render possible specific diagnoses of these neoplastic lesions. EUS is not only the most sensitive technique for the detection of solid pancreatic lesions, but moreover is of high importance for their characterization. A reliable differential diagnosis of solid pancreatic lesions by EUS, including advanced imaging techniques and EUS-guided biopsy, facilitates appropriate treatment decisions. A 71-year-old man presents with significant weight loss and radiating back pain. Transabdominal ultrasound demonstrates a solid mass lesion in the splenic hilum and small hypoechoic liver lesions. Longitudinal EUS reveals a large hypoechoic mass which encases the splenic artery. The adjacent pancreatic parenchyma and the pancreatic duct are normal. A round hypoechoic lymph node is detected in the vicinity of the tumor. The splenic vein is either compressed or infiltrated. Contrast-enhanced EUS using low mechanical index is performed. 15 seconds after injection of Sonoview, enhancement of the splenic artery is observed. Several seconds later, some irregular tumor arteries are detectable. The tumor remains hypovascular compared to the adjacent pancreatic parenchyma. Due to liver metastases, there is no chance for curative treatment, and EUS-guided fine needle aspiration is performed using a standard 22-gauge needle. Cytologic smears as well as histologic preparations establish the diagnosis of moderately differentiated ductal adenocarcinoma. Chemotherapy is initiated. The next case describes longitudinal EUS in a 57-year-old female with an incidental ultrasound finding of a small hypoechoic pancreatic tumor. The hypoechoic and slightly inhomogeneous tumor in the pancreatic body measures approximately 15 millimeters. Color Doppler sonography impressively depicts a feeding arterial vessel branching within the tumor. Blue coding in real-time elastography indicates higher stiffness of the tumor tissue compared with the normal pancreatic parenchyma. Contrast-enhanced imaging using the low mechanical index MI technique shows a hypervascular tumor. All these findings are typical for a pancreatic neuroendocrine tumor. The tumor is sampled using a 22-gauge needle. The aspirated material is smeared and additionally small core particles are fixed with formaldehyde. Cytology and histology show the typical findings of a neuroendocrine tumor. Tumor cells stain strongly positive for synaptophysin, and hence the diagnosis of non-functional pancreatic tumor is proven. Resection of the tumor is performed. A 61-year-old patient presents with unspecific recurrent upper abdominal pain, but reports neither dysphagia nor weight loss. Transabdominal imaging reveals a mass lesion within the pancreatic head. Esophagogastroduodenoscopy identifies a small esophageal neoplastic lesion above the Z-line, finally diagnosed as squamous cell carcinoma. A mass lesion within the pancreatic head is identified using EUS. It is difficult to decide if this lesion derives from the pancreatic head as primary pancreatic tumor or is infiltrating from outside as a lymph node metastasis. Contrast-enhanced EUS with low mechanical index impressively shows arterial hyperenhancement. EUS-guided biopsy proves squamous tumor cells indicative for the metastasis of esophageal cancer. This is a very interesting case of a 42-year-old woman with an incidental finding of a hypoechoic tumor of the pancreatic tail. The tumor has a diameter of around 12 mm and smooth borders, is isoechogenic compared with pancreatic parenchyma, and an internal structure resembling splenic tissue. Color Doppler identifies a feeding vessel. Tissue elasticity is comparable to pancreatic parenchyma. However, the decisive finding is that of contrast-enhanced EUS. The solid mass lesion is highly hypervascular compared with pancreatic parenchyma, and hypervascularity is maintained also in the late phase, an enhancement pattern very similar to that of the spleen and liver. EUS-guided sampling is performed using a 22-gauge needle. Histological examination reveals clusters of monomorphic small cells, most likely being benign lymphatic tissue. Immunohistochemistry is negative for neuroendocrine markers, but the cells stain positive for the T lymphocyte marker CD8. Therefore, a diagnosis of intrapancreatic accessory spleen is made. In summary, characterization of solid pancreatic lesions is based on the patient's history, clinical information, traditional imaging, and advanced endosonographic techniques. Some rare pancreatic tumors are associated with particular age groups and gender, specific symptoms, or patients' histories. Specificity of grayscale EUS is limited. However, absence of pancreatic duct dilatation has a high negative predictive value for malignant tumors. Elastography and contrast-enhanced EUS facilitate differentiation of pancreatic adenocarcinoma from other neoplastic and non-neoplastic lesions. A 90% rule may be applied. In approximately 90% of cases, ductal pancreatic adenocarcinoma is stiffer compared to surrounding pancreatic parenchyma. In approximately 90% of cases, ductal pancreatic cancer is hypovascular with irregular sparse arterial vessels, whereas almost all alternative benign and malignant solid pancreatic lesions are hypervascular. Disappointingly also, the accuracy of EUS-guided fine needle aspiration does not exceed the magic 90% barrier. Combination of these techniques may offer additional diagnostic value. For all solid pancreatic lesions with EUS features which are not indicative for ductal adenocarcinoma, definitive tissue diagnosis should be attempted by EUS-guided fine needle biopsy. Appropriate management decisions will depend on specific diagnosis. However, the majority of solid pancreatic lesions exhibit typical criteria of ductal pancreatic cancer. Staging and assessment of resectability are the topics of the third part of this video contribution. Complementary to CT, EUS provides valuable information for staging and assessment of resectability. Staging of pancreatic cancer is performed according to the TNM classification. T-stage considers tumor size and extension beyond the pancreatic gland, involvement of the superior mesenteric and celiac arteries, and distant metastases are contraindications for surgical resection. For positive findings of EUS-guided biopsy, the prefix P is used. Conversely, a negative cytopathologic finding in the case of suspected lymph node metastasis or distant metastasis is classified CN0 or CM0. Patients with arterial infiltration or distant metastases have a very poor prognosis, and surgery should be avoided. In up to 15% of cases, EUS reveals occult distant metastases. We present the case of a 49-year-old male patient with a large pancreatic mass and suspicion of small liver metastases at computed tomography. Longitudinal endosonography with real-time elastography reveals a large and relatively hard hypoechoic pancreatic mass. Contrast-enhanced EUS using a high mechanical index and color Doppler imaging is performed. After injection of Sonoview, irregular vessels become visible within the tumor. Pulsed wave Doppler identifies only arterial flow signals. Venous signals are not found. Multiplanar reconstruction is performed using raw data recorded while performing a free hand sweep with the transducer across the tumor. Careful evaluation of the tridimensional reconstruction enhances the understanding of the relationship of the tumor with the surrounding major vessels. In this case, encasement and narrowing of the celiac trunk is clearly depicted. Multiplanar reconstruction is also feasible with the low MI technique of contrast-enhanced ultrasound. The irregular pattern of tumor neovascularization and the very close topographical relation of the hypovascular tumor with the celiac trunk and the hepatic artery are clearly visible. Tridimensional reconstruction of the volume data is performed using special software. This mode of reconstruction definitely demonstrates the occlusion of the splenic artery and the involvement of the common hepatic artery. Therefore, the tumor is classified non-resectable and EUS-guided biopsy is performed. On-site cytological examination demonstrates tumor cells with pleomorphic nuclei and dense irregular chromatin. An endosonographic diagnosis is made of ductal adenocarcinoma of the pancreatic tail with involvement of the celiac axis. Enlarged lymph nodes are not detected. Liver metastases have been proven by CT prior to endosonography. According to the TNM system, tumor formula is CT4, CN0, CM1. Palliative chemotherapy is initiated. The last case is related to the potential of EUS-guided fine needle biopsy to prove distant metastasis. A 78-year-old man presents with weight loss and abdominal pain. Transabdominal ultrasound reveals a large hypoechoic tumor of the pancreatic tail. Radial EUS shows that the hypoechoic mass encases the splenic artery. Infiltration of the celiac trunk is suspected. Moreover, the tumor infiltrates a small intestinal loop. Now, longitudinal EUS is performed in order to obtain a histological diagnosis. In this case, the examiner looks for the most advanced manifestation of the suspected pancreatic cancer. There are some suspicious lymph nodes in the vicinity of the tumor. Splenic artery is encased and splenic vein seems to be occluded. The transducer is now turned counterclockwise to the lesser curvature of the stomach, and the left liver lobe is screened carefully. A 12 mm solid lesion is detected, which is slightly harder than liver parenchyma. A 22-gauge aspiration needle is used to sample this lesion. 2 or 3 needle passes are appropriate in the case of liver lesions. Periodic acid shift staining of the core tissue impressively demonstrates focally mucin-containing, pleomorphic and polygonal tumor cells infiltrating normal liver tissue. Liver metastasis of a poorly differentiated pancreatic adenocarcinoma is proven. TNM classification is CT3, CN1, PM1. Infiltration of the celiac trunk is suspected but not proven. In this situation, the category of CT4 should not be used. Finally, we will classify the other cases of pancreatic cancer of the first 2 parts of this video demonstration. In Part 1, the case of an elderly lady with a 15 mm pancreatic cancer was shown. The tumor was restricted to the pancreatic gland, and imaging did not demonstrate any suspicious lymph nodes or distant metastases. Therefore, the resectable tumor is classified CT1, CN0, CM0. However, the patient declined surgery. In Case 4, EUS was highly suggestive of pancreatic cancer, and no criteria of non-resectability were found with EUS, transabdominal ultrasound, and CT. Therefore, surgery was performed. However, due to infiltration of the celiac trunk, resection was impossible. Intraoperative biopsy proved adenocarcinoma, and final classification was PT4, PN1, CM0. Palliative treatment was initiated. This large pancreatic tail tumor encases the splenic artery. Due to involvement of lymph nodes and liver, staging diagnosis is CT3, CN1, CM1, and palliative chemotherapy is indicated. In conclusion, EUS is a valuable method for the detection, characterization, and differential diagnosis of solid pancreatic lesions. This flowchart presents a structured approach to diagnosis and staging of solid pancreatic lesions. Elastography and contrast enhancement supplement clinical data and B-mode EUS. Typical features of ductal pancreatic adenocarcinoma are hypovascularity, low tissue elasticity, and failure to detect venous vessels within the tumor. Due to the high positive predictive value of those criteria, EUS-guided biopsy is not necessary in resectable tumors. However, if non-resectability is shown, EUS-guided tissue sampling is performed before palliative treatment is started. Hypervascularity, detection of veins, and relatively low tissue stiffness of a solid pancreatic lesion are strong arguments against a diagnosis of ductal adenocarcinoma. Various benign and malignant lesions share those characteristics. Therefore, in this particular situation, EUS-guided biopsy is performed to obtain a specific cytological or histological diagnosis of non-ductal pancreatic neoplasms and benign solid lesions. A reliable specific diagnosis provides the basis for appropriate treatment decisions.